Well, welcome back to our session 2, the last session of the symposium for today. And just a quick reminder that through your Q&A feature at the bottom of your screen is how you ask questions to the presenters. And the chat feature is how you can make comments that are not questions, and where you'll be seeing information coming from us as your host throughout the rest of the afternoon, different links and information that we think will be helpful and relevant to what you're going to be listening to. So this is an exciting session, and you'll be hearing from some presenters, and then we'll be having a panel with even some additional people on that. It's a creative kind of afternoon to go high and go low, get deep on some of these issues. So we are excited. It is my honor and pleasure to introduce our first presenter, Maggie Buckley, who is with the pain community and the Ehlers-Danlos Society. And she has many accolades. You can read her full bio on the presenter bios page, but I have the pleasure of getting to work closely with Maggie through AACIPM and her enrollment and engagement with the pain community as our fiscal sponsor. So I will now turn it over to Maggie to share her thoughts with us today. Thanks, Maggie.
Thank you, Amy. First off, I've been asked to share a little bit about what those initials after my name mean, BCPA. BCPA means Board Certified Patient Advocate. And the Patient Advocate Certification Board was organized in 2012 to establish ethical standards, professional competencies, best practices for professionals who work in the emerging field of patient advocacy. All of us here know that healthcare has become such a complex system that patients and families often face enormous challenges. So health and patient advocates can provide valuable assistance in navigating such a complex system. All right, let's move on to some real world examples from the perspectives of people with pain. So in preparation for today's symposium, I've been asking people with pain about their experiences in 2020 so far. The first person that I spoke with is a very complex chronic condition and has needed and received multiple interventions this year despite the COVID restrictions. He's had specialist consultations and rehabilitation care in this calendar year, and he's grateful that he's received what he deems excellent and appropriate care through Medicare. This individual actually has a high level of education and lives in a metropolitan area. So I wasn't surprised by what he had to share. We all hear about how telemedicine has increased access to healthcare in the age of COVID. And reviews from patients that I've spoken with are a mixed bag. Members of the rare disease community see it as something they've been asking for more of for decades, and their reasons resonate with the larger community of people with pain. This healthcare delivery method increases access to specialists without the financial and physical expense of traveling a great distance. For those with reliable internet and telephone access, this is a more efficient way to receive care, particularly in the rural population. As an example, one family living in a rural area 8 hours north of the San Francisco Bay Area, where they go for healthcare to manage a painful genetic condition, shared that their quality of life and their financial position has improved this year because telemedicine has eliminated at least 3 trips so far. And that means more time at home, less time traveling, less financial drains, and less stress. They've been visited at home by technicians to draw blood and even to do an EEG for one family member. The family member has one parent on Medicare and a young adult on Medicaid. Mail delivery of prescriptions also reduces the need to travel an hour away to pick up prescriptions. Another urban family shared that their limited resources mean they share a mobile phone amongst the family, a single phone, and they don't have internet access at home. And that phone needs to fill in for home education for the children, work contact for one adult, and as a healthcare portal for all of them. They found it challenging to schedule telephone visits with healthcare providers while juggling all of these other needs and the need to leave their home to go and find internet access at fast food places or libraries. Another theme that I heard from people is that restrictive prescription refill systems are a frequent frustration, whether they have private insurance, Medicare, or Medicaid. Some had to change providers at some point this year because some providers have gone out of business or been unable to maintain their offices. So that has required these individuals to change to a different position. So they're frustrated that the regular prescriptions that they've been taking for a long period of time did not transfer over directly. For some, it's an issue of allergies to medications or inactive ingredients in some formulations. These special needs have been ignored in this transition. And then that becomes very costly because they are receiving prescriptions and paying a copay for prescriptions that they can't really take simply to follow the rules of their pain care provider or the pharmacy. One woman shared that she was told by her pharmacy that it's the pharmacy's policy to always fill with a generic for Medicare patients, no matter how the prescription was written. So there's a lot of frustration that the prescriptions aren't being filled as they are written as well. So it's another area to consider. There's a Medicaid recipient in West Virginia who's being forced to taper off of an opioid. Her physician of 26 years has already reduced that dose in recent years to the lowest therapeutic level. That makes it possible for this person to engage in self-care, including physical therapy, meditation, and yoga, amongst many things, as part of an overall pain management plan. It doesn't seem right that if there's a stable, established relationship of 26 years with a physician, that simply because these rules, the legislative changes to how prescriptions for opioid pain medications has changed, that this person now is being told they can no longer have something that has worked and made it possible for them to participate in life. All of these people that I've spoken with use many modalities to manage their pain. Those who've relied on integrative therapies such as acupuncture, massage, therapeutic yoga, and supervised physical therapy pre-COVID have found it challenging to continue or to resume these helpful interventions. Telemedicine does not yet translate to the delivery of all of these important services. Durable medical coverage is another topic that comes up quite often as being inconsistent or downright frightening. One person requested repairs to medical equipment several times last spring. By midsummer, he was no longer able to stay safely at home and was moved to a care home. And his family is hopeful that the needed repairs will be made soon to the wheelchair and walker that he relies upon to live safely in his own home. In the meantime, they're very concerned about him being in a care home and his exposure to potential infections, etc. Another woman was fitted in April for a lightweight, slim wheelchair to be used in her home. In August, a heavy chair was delivered to her home that is so wide, she could fit two of her inside that chair. Plus, the chair doesn't fit through the bedroom or the bathroom doors in her home. So again, there's this Medicare expense that leaves everyone scratching their heads. Why did it happen? And when she called the company that delivered the wheelchair and asked them why this happened, they said, oh, they upgraded her. So upgrade is kind of a scary term for this group of people. Another woman had been upgraded by her healthcare team from compression leg braces to compression stockings, only to learn that the stockings were not covered by Medicare or Medicaid, and they were prohibitively expensive for her to purchase on her own. So the cost comparison of the compression leg braces, which needed to be adjusted by an orthotist several times a year, as opposed to a one-time purchase of stockings, seems questionable. It raises questions. It's not all bad though. These people are having some positive experiences and they've expressed some hopes for the future. Everyone I spoke with is hopeful that the lessons and adjustments being made in 2020 to our healthcare delivery system will benefit everyone in the long run. Keeping and expanding telemedicine options for all, for example, could be enhanced if there's an in-office tech support for providers and for patients. A few people suggested that as they log on for a video appointment, there should be some indication of how long they will have to wait before their appointment begins. These are minor things, minor tweaks, etc. The largest expected benefit here is that specialists may be consulted without the physical and financial costs of the past, especially if the specialist is in a different state. For example, the ECHO program that our next speaker will discuss is a fantastic program that brings the experts and specialists to a local, often rural clinic. And it's used for training all stakeholders in organized efforts like the programs provided by the Ehlers-Danlos Society. Folks are hopeful that the regulatory differences by state will be standardized to facilitate interstate telemedicine on an ongoing basis once we've made it through this pandemic. They're looking for some kind of care, some kind of coordination and tracking of care from different providers within different systems, or at least making it so that electronic healthcare records are in the same or compatible infrastructure. The biggest ask from people is to expand access to integrative care options so that they would be able to access these options wherever they're at the clinic, in the emergency department, and through home healthcare or telemedicine. Finally, I'd like to share with you a recent experience I had seeking care for an acute flare of a chronic pain condition. I'm a Medicare recipient with a multi-systemic chronic pain condition, so the decision to visit the emergency department was not made lightly. As a matter of fact, there were 2 telephone and 1 video appointment in the 24 hours prior to the trip to the emergency department. The staff there were very concerned with getting me pain management. And at one point, a doctor was listing prescription options of opioid medications and was getting very frustrated because I was declining them based on my past experiences with those medications, and or they were contraindicated for the type of abdominal pain that I was experiencing. The doctor was exasperated and asked what I had previously used in this situation. And my response was acupuncture, which has not been available to me due to COVID-19 restrictions. She said she completely understood and that she too was frustrated that acupuncture was not available in the emergency department because of her military experience and known success with battlefield acupuncture. It made her certain that it works and it's appropriate in this setting. Her frustration is that it's not an option, it's not a tool that she has available to offer patients as they come into the emergency department. So now I ask all of you, how do we move forward toward a healthcare system where integrative treatments are available at all levels of care? Thank you.
Thank you, Maggie. That was really excellent and insightful, and appreciate all the time and effort you put into talking with so many folks to bring more voices into this conversation.